Hey everybody, welcome to the Shreveport Local Lens Podcast. I'm your host, Jeremy Sutton. I'm here with Dr. Jeff Pearson at FlexInstitute, and we're going to talk about his practice and their practice and all things orthopedics. How are you doing?
I'm doing great. Thanks for having me.
Yeah, thanks for being on. So let's just start out by introducing yourself. How did you get into orthopedics? Why?
Sure. My name is Jeff Pearson. I'm a local guy from here, born and raised down the street, went to Byrd High School. Had a few injuries in high school like most guys do, which kind of introduces them to orthopedics. I actually broke my leg running to lunch at Byrd in the 10th grade. Fell down the stairs on Turkey Tet Day. And that was the first time that I got introduced to this world.
Well, it couldn't have been a cooler story.
That was
it.
Yep.
Awesome. So, had an injury. What made you decide to go orthopedics route?
It's very, for the most part, very black and white.
Mm-hmm.
There's a lot of things in medicine that are much more gray, much more subjective. I'm a very concrete black and white kind of guy, and orthopedics fits that for me. It's a very, there's a quick change in someone's life. You know, a total joint replacement can alter someone's life pretty dramatically, pretty quickly, and a lot of medicine, it just takes longer to kind of get to the end result. And this is a very cut and dry, quick change.
Right.
Which I enjoy.
Yeah, I love that. You know, when I got into physical therapy, I didn't know we did wound care. You know, this was when I was 19, long ago, and I really like the wound care aspect because you can see, did that hole get smaller?
Yeah.
Is there something coming? You know, it's like I said, it's black and white. Where a lot of times if you're rehabbing a rotator cuff or something like that, you're like, I hope you're getting better. Right? We see certain things. What molds how you treat people in your practice?
It's a great question. You know, I really try to educate the patients. I try to really teach them what's going on, present them with the options, and really kind of let them dictate their care. I really try to really, you know, be as educational as I can and really let them kind of choose their path, because every patient has different goals and what they want.
Right. Like if you have somebody that just wants to not hurt versus somebody who wants to keep running a marathon.
Sure.
Things like that. What specific surgeries do you focus on right now, Dr. Pearson?
Mostly, I would say hip, knee, and shoulder. I did fellowship in hip and knee replacement, so I do a lot of anterior hip replacements almost entirely, and then I do knee surgeries, knee scopes, and knee replacements, and I do some shoulder replacements also.
Awesome. And are you using the Mako or any machines or anything like that?
That's a great question. It's a hot topic in town.
Do I need to back up?
No. So I do some Mako robots. I've got some hot takes that I think is probably inflammatory for this city. This city's pretty Mako heavy. It's a great technology that I think does not recreate the normal anatomy that other implants do. So I use a different implant mostly, but I think personally as a much more anatomical implant.
Okay.
The Mako is a great implant. It was developed, the Mako implant itself was developed 20 years ago, and so I think there's newer things on the market we can put in that a little more advanced technologically.
What do you use and what do you recommend?
So I use something called the medial pivot knee. It's a medactic knee, and so I do something called kinematic alignment. It's a little different than the robotic knee. So basically, every knee that is put in around most people, you know, we kind of put it in flat to the ground and we put it in very precisely, but it's kind of a cookie cutter knee replacement. So I do something that's a much more, I'd like to think, natural feeling, and and basically it leaves the knee joint line how God made it.
Okay.
So it's in a nutshell.
Okay, well I like that because I think God made us perfectly, and I want to be as much like that when I die as I was when I got here. What have you seen that's the most important thing for a successful orthopedic outcome after surgery?
Certainly, I mean the patients and how hard they work in PT, especially for knee replacements. I think for hips it's not quite as important, but for knees, the amount of work that a patient puts in the PT is directly related to their outcome. It's all about the therapy afterwards.
Yeah, I think so. It's funny because, you know, 16 years being a PT, I've seen maybe a handful of people say, hey, I'm going to do my rehab at home after a total knee. And my response is always the same. You're going to be the first person in the history of the world to do this, and you're going to be back in 6 months miserable.
Therapy is super, super important.
Yeah. And I think sometimes people say, well, there's a lot of active people that have knee replacements. Well, I've been exercising. I remember I had a black belt in karate one time. Oh, I'm going to do this at home. And you just don't. You can't make yourself do the things you need to do to get better.
I think a lot of patients don't quite realize that there's way more to PT than just simply stretching and bending straight. I mean, there's just tons of techniques and therapies that they have to offer that are well beyond what you might think you can do on your own, or what you think you can do at Planet Fitness. Is just so much more in depth than that.
Yeah, absolutely. I mean, there's one of the things that I've learned as my parents have aged. My dad passed away a couple of years ago, but just being in the office or in the hospital with them, like, they have no idea what they're talking about medically. Like, my dad was super intelligent. My mom's a teacher. She's intelligent, but they just don't know medical knowledge.
Yeah. And
so you're hearing all this stuff, and you're like, it's not that big of a deal, but it is.
Yeah.
And if you don't know what you're doing, you're not going to get better.
Sure, certainly.
Awesome. What do you do? So I know you're not just cutting everybody that comes into your office. How do you go through that process with them? Hey, surgery's not the right option yet, or this is what we need to do?
Yeah, we kind of look at the whole picture. You know, it's not just, you know, a BMI number. It's not just an age. It's kind of an entire picture. We look at their social support, you know, what their goals are, how bad their function is. I really try to look at someone's function and their pain level. And is this really interfering with their quality of life? And patients will eventually get to the point where they say, hey, enough is enough. I'm tired of driving around the parking lot looking for the front row parking spot. Let's do something. And then from there, we look at your risk factors. Is this right for you? Is there something we should optimize or kind of tune up ahead of time? And if we're as tuned up as we got to be, then we have a discussion about the risks and the benefits, and then we make a decision together.
Yeah, I love that. You know, talk about why. So I saw an 87-year-old lady yesterday. One of her neighbors just had a hip replacement. She's like, there must not be that much to a hip replacement. Why is it that the knee is worse than the hip?
So, you know, the hip is a much simpler joint. It's a ball and socket joint. There's one single axis of rotation. It's a ball and socket. And then especially on these anterior hip approaches, you don't actually cut through any muscle. And so it's just a quicker recovery. You know, they've done studies looking at markers of inflammation and markers of cutting through muscle. And basically, that's all lower going through the front. And even through the back, it's just a quicker recovery than a knee. The knee is a much more complicated joint. It's part hinge, but you know, like a hinge of a door, but it also pivots about a different axis of rotation. So there's several different axes of rotation. It's just a much more complicated joint, right, and that leads to a harder recovery.
Yeah, for sure. This may be a hot take question. Yeah. I haven't asked anybody yet, so you're the lucky person. Why are we still doing the posterior approaches to hip replacements? Why aren't we just all doing anterior?
Yeah, so a few reasons. I think, you know, everyone is slow to adopt technology. When I'm 10 years into my practice, I might see something new and be slow to adopt, because the one mindset is, hey, what I'm doing works fine.
Right.
There's also just a barrier to entry and taking the time from your practice to go learn something new, and you don't want to risk complications and things like that. And I will say the studies show pretty clearly that long term, a year out from a hip replacement for the front or the back, at a year, the outcomes are the same.
Right.
And so you have a quicker recovery curve early on, but by 12 months, they're the same. And so one could argue, hey, why am I changing? Because at a year, it's no different.
Right, yeah. But from the PT standpoint, and my mom's about to have a hip replacement, yeah, I'm like, let's do anterior, yeah, because I don't want this to be miserable the first few weeks.
Sure.
Yeah, well, I like that. So I've honestly not thought of that from an orthopedic standpoint before, like, you know, because we have to go get continuing education every year. And so I've learned dry needling. I'm working on diagnostic ultrasound right now, but I don't have to stop what I'm doing and go learn a surgical procedure. So that makes a lot of sense. Yeah. Awesome. What's your favorite thing to treat?
I really like taking care of hips. Patients are just so happy after hip replacements, especially if you really need it. The outcomes are just, hip replacements are up there ranked with cataract surgery, some of the most change in quality of life and most successful surgeries. And so they're just so happy afterwards, which is nice.
I love that. So my mom, she needs bilateral hip replacements. Yep. She's had a lumbar 360 fusion. Yep. I was stretching her one day and I moved her hip, and I'm like, hey, this is called a bony block. That means your hip's not going to move. And so I don't know if you know this, but you can't treat your family. I know you know that. But anyway, so finally I talked her in, and so she's going to have both hips replaced in the next year. And I was like, this is going to change your life. You know, and she doesn't quite grasp that yet, but it really is, because exactly what you just said.
It's a big deal.
It's a huge deal. Whereas when they have the knee replacements, it does change, but you still got a recovery. Yeah. And we spend a lot of time saying, hey, you need this surgery. It's going to be okay. Let's go. One of the things that I talk to a lot of my orthopedic patients, mainly total knees and rotator cuff repairs, because those are the two hardest from my end, is, hey, you're going to have days where you wish you hadn't have had this surgery.
Oh, yeah.
That's normal.
Mm-hmm.
Let's just try to get through that. Do you prepare people beforehand to talk about that?
So I tell patients for knees, kind of the expectations are super important for patients to have. And I tell them, like, look, the first few weeks are going to hurt. Week 2, week 3, week 4, you're going to say to yourself, I should never have done this. Mm-hmm. And you're going to say to yourself, I wish I never would have met Dr. Pearson. And that is totally normal. Yeah. And even 3 months, patients still hurt. They have nighttime achiness when they lie down at night. Like, that is normal. And I tell them, you should expect 6 months until you can do things like stairs without pain. Mm-hmm. The goal, the holy grail for me is this forgotten knee, and I tell them that takes a year. Mm-hmm. It is a long road for a knee, and I do not expect an overnight fix. Yeah,
I like that. I think it's important to tell people those things, and sometimes I get people and they're like, the doctor never told me this. I'm like, I bet he told you. Yeah. So that's good to hear. Well, so your practice has a new name.
Yep.
FlexInstitute.
FlexInstitute.
What's that about?
We have been orthopedic specialists for ever since I was a little kid here, growing up in town, and I'd say our branding can be somewhat confusing. We've got the Spine Institute Specialist Hospital, we've got the Pain Care, we've got Musculoskeletal Institute of Louisiana, Orthopedic Specialist, all this stuff, and so we're trying to kind of streamline some branding to make it easier for patients. It's Orthopedic Specialist of Louisiana is kind of a mouthful.
Yes.
And so we really are just trying to modernize our brand and streamline some things to be all under one roof. We've got our pain care doctors under the FlexInstitute, so we're just all just trying to modernize some things and kind of come up to the 21st century.
Yeah, I like that. And it is much easier to say FlexInstitute. Yeah, I love that. And I know Dr. Masura personally. I've known him for a long time. He's phenomenal. And met some of the other doctors. Yeah. And of course, I've been practicing around Shreveport for 16 years, so I've seen hundreds of people from out of this building, which is great. So I'm glad that the new name and excited for the direction.
Thank you.
What are you super excited about right now, like going into the future, either medicine or your personal practice or whatever?
I think there's just so much potential as we get the next 20 years. I think biologics is going to come the next big thing, and orthopedic surgery, and kind of using what biologic is we have developed the metal, plastic, and metal parts for the last 50 years in orthopedics, and I think the next frontier is how are we using biologics, collagen and soft tissues, genetically modified, whatever, in labs, or these stem cells, things like that, to kind of enhance recovery, speed recovery, and change outcomes. I think that's kind of the future, which I'm excited to see what comes up from that.
Yeah, it's amazing to me the things that we can do every year. We just get a little bit better at doing things, and which is why the hips are better and the knees are better now. What do you see the role of the artificial intelligence moving forward in medicine?
I think the big thing there comes into the economics at play. I think certainly to some extent it'll take a huge chunk of mid-level care. Mm-hmm. I think a lot of mid-level providers will be using it more. The primary care field will there'll be a lot of triaging and limiting access to physicians as the shortage grows and there's more patients, and so you'll kind of have to weed through some chat GPT triage of diagnosis until you get there. And on the back end side of things, every year reimbursements for healthcare goes down, and expenses go up. The overhead goes up, the health insurance goes up, and you'll see AI to replace a lot of the office staff work that years ago was done by hand, sending faxes, getting authorizations, all that. Eventually will, for good or for bad, go towards artificial intelligence. Yeah,
I think you and I talked before the podcast. I use it every day, and just to write social media posts. Yeah, I can't. My wife told me about 3 weeks ago. She's like, "This is the best post you've ever written." I was like, ChatGPT wrote that. That's she's like, "Oh,
it is here to stay. It is here."
And I think. So from my side, I don't see it replacing me, but I see it enhancing what I do and what you do. And I think if the longer you resist it, the further behind you're going to be.
And I can see it being used as some sort of stopgap measure. And in diagnosis, you upload your thoughts on a patient, and maybe there's a diagnosis you didn't think about. Mm-hmm. And so it could definitely be helpful. For patients.
Yeah, I love it. I mean, it's helped me a lot. I certainly don't use it to make my decisions, but if I'm trying to work through a situation exactly like what you just said, then it's like, hey, what do you think about this? Oh, we'll try that. Oh, I didn't think about it. It's just really good. It's a tool. Awesome. Dr. Pearson, thank you so much
Yeah,
for being on the podcast. I appreciate it.
Yeah, dude.